program status update, and some updates in response to feedback, and then some resource documents that you'll find, and then any Q&A along the way. And if there's things that we need to take a pause on and answer as we go along, that's completely fine as well. Next slide. So we announced this, and I think probably most of you on here are aware, we revised the launch date. We haven't launched it. We were planning on launching September 1st. It's now January 1st. And there's a few really important reasons as to why we wanted to delay. One is we got some really great questions from many of you listening in, and from others about technical details, as well as some major programmatic questions that we wanted to make sure we took time, thought about, and responded to, as well as identified if there was opportunities for programmatic adjustment. And so that's the main reason, obviously, we're meeting today and still seeking input and individual opportunities to connect with many of you one-on-one. So next slide. So just an update on kind of where we are, things that we've accomplished to date, and that many of you have seen, is some of the modeling and program testing that led to draft case rates being put out there, as well as some updated information about those about the case rates that we've also released in August. There's historic performance reports, some provider resources, including video guides and FAQs. And then there's other things we are currently working on, things that are upcoming. So we've been considering some of the questions on programmatic refinements. We have an updated FAQ that's live. There's a quality measures reference guide, and there's also a billing example. We're still in discussions with CMS, but anticipate CMS state plan approval pending further conversation. Some upcoming ones are provider bulletins and payment policies and processes, final performance year case rates, so updated case rates, and then performance year provider reports. And again, information on anything we've put out there will be available at our website. Next slide. So here's a few things that we've heard questions about, and we're going to list some of them and discuss those today. And so we have been very much deliberating intentionally and for quite some time on a few of these questions. And so we're going to talk about case rate development and program monitoring, attributing cost to MFM providers, family medicine exclusion, billing for members with TPL coverage, and case rate services. Next slide. So case rate development and program monitoring, just a reminder here. And one of the big questions I know we were asked was about reconciling the case rate. What does that even mean? So basically reconciling expected fee-for-service revenue based on shadow billing to what is actually captured or what paid to practices via the case rate. And so there is concern that from many providers that they may be underpaid via the case rate compared to fee-for-service. We went and we talked about it internally. And one of the major concerns was that due to both budget constraints and federal authority, that we would be forced to do upside and downside reconciliation, meaning that if providers receive more than in fee-for-service, that we'd have to actually take away some of those dollars, or take away those dollars down to fee-for-service, in addition to being able to reconcile up. And given that we anticipate additional dollars going out via the case rate as part of this program, including $4.5 million in state fiscal year 25, probably a little downward. That's prior to our delay, so that will be downwardly adjusted slightly. But 6.2 million in state fiscal year 26, 6.3 million in state fiscal year 27. And so those dollars potentially will be at risk if we actually look to launch that. And we announced this previously, but we did go back and discuss it again in light of a lot of the comments that were made. I just want to point out there is additional dollars that will be going out through on top of the case rate. And again, the case rate's been developed using historical fee-for-service claims. The additional dollars go on top of that developed case rate. For lactation support, that will go out across the board. That's $7 PMPM. And for those who haven't opted out, there's also the $14 PMPM for doula services. In addition, there's the opportunity for shared savings payments. That's upside only. So again, that's going to be based off a risk-adjusted, socially and medically complex risk adjustment, expected spend compared to the actual spend. And if there's savings, and depending on people's quality scores, there's opportunities for additional payments to be made as part of that retrospective reconciliation. So we anticipate that additional dollars will be flowing to providers, and we think there's not a good reason and actually harm if we were to do a upside and downside case rate to fee-for-service reconciliation. Next slide. So one of the other questions related to what we just discussed was case rate development and program monitoring. And so we are planning on monitoring member access, practice revenue, and billing patterns to help make sure that Husky Health members have access to excellent maternal health care, and also to ensure financial stability for participating practices and providers. And so we have rigorously developed the case rate in the first place. Understandably, I think there's always concern when anything new is being done, and we have sent out historic case rates and are refining with updated data for that go live case rate that we'll be providing shortly. The program monitoring, so we will be planning on monitoring as above, using our large team to look at, again, patterns of revenue generation, billing patterns over the course, especially this first year. And then we do have the ability to rebase the rate after 12 months. So we'll be looking at to do that based on risk adjustment and trend factors, and also to account for risk mix or service delivery over time. Next slide. Another question that's come up several times is about including maternal fetal medicine providers. And so we carefully went back and thought about this. There's a lot of initial discussion about trying to include as many individuals under the maternity bundle as possible, including those highest risk. And we know that MFM providers do provide very high risk, often very high risk services to high risk members. We understand some of the concerns that have been raised, but after ongoing consideration, DSS is planning on continuing to include the MFM providers as part of the case rate. What that means is just an example here is provider implications. In-house MFM services that are provided within the tax ID or TIN will be reimbursed by the case rate. So if I'm a OBGYN or I'm a nurse practitioner, and I, underneath the practice, also have an MFM that's under that same TIN, that case rate's been developed with the setting of both of those providers, or the providers being there. That case rate, that once it's started, will pay for both of the services underneath that TIN. So if the MFM provider that's working under the same TIN as myself, who again is a OBGYN or certified nurse midwife, those claims that would go out would be zero paid for both MFM providers and the OB or certified nurse midwife. So if there's an external MFM, so say there's a MFM down the road or participating in another town that's in a different tax ID, the case rate I would receive as a provider would not be for those services if I was referring out to an MFM. If the MFM provider is a maternity bundle provider, they can receive a case rate independently and separately. So both as the OB and also the MFM, both could receive a case rate in the same month if both are submitting trigger codes and diagnoses. I know that could be complicated, so feel free to ask for any clarifying questions in the Q&A. We understand there's still ongoing, some providers will have ongoing questions about this in the future, and we're happy to answer those. Next slide. So attributing costs to MFM providers. So one thing we wanted to do to help provide a little bit more information to larger provider groups that might have multiple MFM providers or have an MFM provider group underneath is provide supplementary provider-specific data as part of the first-year case rate to kind of help the larger organization understand what portion of the case rate is associated with service delivery by MFM providers within that tax ID. And so we just understand that might help with some of the internal accounting practices that providers may be thinking about how to operationalize this on the back end. So we are looking to provide that additional information and hopefully make it easier for those larger providers to incorporate the case rate. Next slide. Family medicine exclusion. So at the launch of the program, we had said we'd like to be as inclusive to potential maternal health providers as possible. So we included family medicine as a potential provider within the maternity bundle. After looking more closely and some feedback from various provider groups, including potentially some of you, identified that the family medicine providers appear to be providing mostly primary care services and not maternal health specific services, but they might be, hypertension for maternity care, but it's really under a practice that's primary care specifically. And so after consideration, we decided to exclude providers so that those primary care services won't get included in the case rate and not cause confusion at the tax ID level for those larger TINs. We did get some feedback after the last provider forum that there may be a practice that we need to look more closely at, so we are investigating that. Again, we are looking to make this as streamlined in terms of reduce the complexity and make it work at the provider level as possible. But we also want to make sure that we're being inclusive of providers that are providing these services. So as of now, we are excluding those family medicine providers. Next slide. Billing for members with TPL, third-party liability coverage, so those who have other types of health insurance that's covering them. Historically, how this has worked is if there's a member with TPL, or we can tell in our system, usually what's happening is those bills are being paid by the TPL, then we receive a separate claim and we're paying fee for service when it's appropriate to make up any gap from what's not being paid by the third TPL, by the other insurer. Initially, we had said we would pay case rate for these members who have TPL, but after talking with many of you and others, we kind of reversed that decision and said we would pay for members who have TPL, who have a paid TPL claim. We would continue to pay that in a fee-for-service process manner that we currently do. That's really to hopefully make it easier on the billing side and also the practice side, especially because we know most TPLs insurers not us are still encouraging the use of the global code, which creates complexity as we understand on the back end for many practices. So again, for members with TPL, we will continue to use the standard fee-for-service processes that currently exist. Next slide. Case rate services. So we also received some feedback about some specific codes. So if you're interested in codes and you haven't seen them, they are on our website. Which codes are included in the case rate. Specific ones that were asked about were for preventive pediatric and adult care services, 99381 through 99397. After internal review and analysis, decided we would exclude those from the case rate moving forward, minimally used. They would be paid fee for service if they were billed and would not be, again, not be included in the case rate. Next slide. So there are some additional resources, which I referenced some of them, but I just want to highlight them again and make sure everyone knows where to access them. So again, these are our updated program FAQ. So new questions and guidance that have been put out there, many spurred from questions that you all have asked, great ones. And so we've tried to answer as best we can. If there's additional questions, please add them. We're looking to have the FAQ be updated as much as needed. There's a quality measure reference guide that's also now live. The billing example, as I noted, and the updated code list. On the last slide we discussed, we made some adjustments, so the updated code list is available. And again, you can find this on the PSS Maternity Bundle website. I think that was our last slide. Looks like we might have a question. A few questions. Let's see. Any of these, Tiffany, any of these answered already? Probably not.
No, these are new ones, so we can just go through them. I'll read them out. So regarding the recent quality measures document provided, can you confirm that only 3 of 5 pay for reporting measures are submitted via encounter form?
Great question. I'm going to see if one of our just sort of really explicit, or one of our CHN team members wants to jump in just to make sure we're answering as precisely as possible. Let me see. And if not, we'll be able to make sure that should be clear documentation that we have. Kim, do you know if anyone's on?
I'm actually pulling up the documentation.
So why don't we circle around on that in just a second if you have a chance to do it, and maybe we'll answer the next question and come back.
Okay, our next question is, will DSS provide examples of EOBs we would need to see them for the zero paid claims, the actual maternity bundle payment, and the lactation consultant add-on payment.
Sandy, are you on by any chance?
I am. So we are not gonna have a different code for lactation or doulas. I'm not sure. Is the question in the chat?
It is. It's in the Q and A.
Find
It's
Okay.
will, yes, I provide examples of EOBs, question mark. We would need to see them for the zero paid claims, CO 97, the actual maternity bundle payment, and lactation consultant add-on payment.
Okay, so I guess
And
when
Sandy,
you say
you need to
you
take it
want,
back.
I mean, I'm not sure what kind of examples you want, like you're looking for a 9 and an 835 response. I mean, we don't usually,
Okay, so
have-
this is Carrie. I'm sorry. I'm the one that actually posed that question. So we have a vendor that actually handles the batches that come through, and they're requesting to see a copy of all of these 3 situations so they know how to set up their systems and what we're supposed to do with these claims, because we also have to train our staff, because I can't have them working on CO 97 denials. Because that is a commonly used adjustment code for other reasons as well. So we need to, and we don't know how to post, towards that. So if we see an example of an EOB, we can try to figure out what internal processes we need to do in order to make all of our claims, fall out properly, and that we can do our own internal reporting to ensure that this is all being handled correctly.
like an electronic copy of an EOB?
Yes.
Okay, I guess I'll have to take that back. I'm not sure we've ever done that before, so I'll have to.
Okay, because we're just wondering if you're gonna have on those zero paid claims with the CO 97, are there going to be any other carks or works on there that can help us to figure out, okay, this is a DSS maternity patient versus, something that was done that was included in, a surgery that was included within another surgery or something like that.
Yeah, I think we did. It was CO 97, but there was another code that I think we had indicated would be on that also. But I'll have to find that. So
Okay,
let me
thank
look
you.
for it while we're still on the call.
And we can jump back to the first question, Sandy, if you want to see if you can find it. And if not, we can always circle around, obviously, on that.
Okay, it might
Yeah, so
be
this is-
M15. It might be the work that we were posting with the CO 97. But I'll double check.
Thanks. Kim, any chance you, any luck?
Yes, so so out of the 5 pay for reporting measures, 3 of the measures are derived from the encounter form submission, and then 2 of the measures would be from claims data. So doula utilization, breastfeeding support, and behavioral health risk assessments would be derived from the encounter form. So you're correct, Angela.
Great. Our next question is, where's the listing of the maternal adverse events? I do not see them in the quality metrics guide. Great question. That one we actually posted in the updated FAQ. We've been adding some questions around quality measures there specifically. The reference guide is intended to be a quick document to look at the measures, so you can find more information in the FAQ.
Thanks, Tiffany. Sandy, I suspect you might need another moment to get an answer, but feel free to jump in whenever, if you're able to find that. And if not, we can make sure to circle around on that or include it in follow-up FAQ.
Okay, I'll let you know when I find it.
Any other questions? Folks are welcome to type and or jump in verbally as well. Seeing none so far, we can kind of do a relatively quick wrap up. But I'll give, get slight delay tactics. So Sandy, see if she has a chance to find that exact response, and not, we can circle back around on it.
Okay, I did find it.
Okay.
So it is the CO 97 and M15 is the arc.
We're M15, M15.
Yep.
Great.
And then I'm not sure if was was there another question in there?
Carrie, is there another one that you were looking for? Just want to make sure we got it. If we still have it.
The actual maternity bundle payment. So the
Yeah.
actual payment will be it'll be in the bottom. It's like in our remittance advice, it's kind of like the financial transactions. It won't be like a claim. It won't be in the claim section. It'll be
Excuse
in
me,
the
would we
bottom.
be able to get a copy of what you're looking at?
I'm not looking at anything right
Oh,
now.
okay.
Just in
Thought
my
you were
mind,
reading
thinking of a remittance advice. And at the bottom of a remittance advice, I know the paper version there, you have the first sections of the paper remittance advice, or the old paper remittance advice is your claims, your paid claims, then your denied claims and your adjusted claims. And then there's a bottom part where if there's non-claim specific recoupments or things like that are on the bottom, that's where the case rate payment will be. There'll be an indication of who the client is. And it'll be a certain reason code, and the reason code will be for maternity bundle payment. But it will not differentiate the case rate payment from the lactation payment. It's all just one payment. So it's the okay, I can maybe I can on the 835. I'm gonna copy and paste something in the, if I can figure out how to paste this in the, it's not in notes, right? It would be in the Q&A section.
Yep. If you're able to. I don't know if you're able to or not, Sandy. If not, you guys chat it directly to me or to Tiffany, and I'm sure we can enter it in.
Okay, I can do it in the chat. Is that
I think that works, Sandy.
Yes.
okay? So that's the information for the case rate payment.
That's gonna be extremely difficult to coast to. Because we're gonna have hundreds and hundreds of pages of a remit, and to have to reference that at the end, it's just gonna be very hard to do that.
So we are also creating a supplemental file that I think is going to be where are we posting the supplemental file? That would be easier to download and not sure who we were giving that to. So there's a supplemental file that we were planning on creating with the case rate information. We were going to put out on the providers, where the providers pick up their remittance advices. We're going to put a supplemental file there. And I believe, Deb, correct me if I'm wrong, we're doing it based on the provider. So this information that goes on the remittance advice is going to go on the remittance advice of the there could be multiple AVRS provider IDs numbers under a TIN that are getting the case rate payment, like if you have an OBGYN group and then maybe a nurse practitioner group and you all have the same TIN number, and the case rate payment is only going to go on the remittance advice of one of those providers. I think we picked the one that is the primary number associated to that TIN, or that has been paid the highest amount. We're doing a supplemental file that will kind of break it out. So for each of so if there's 3 providers, groups within that TIN that are getting the case rate payment, there'll be a separate file for each of those individuals with the case rate payment and the name of the client associated with them. So it won't be just in that one remittance advice.
So will that automatically be sent to us, or is that something that we have to go out on the site and pull down ourselves?
You'll have to go out to the CTDSS map web portal to pull it down.
So this is Valerie. I'm with the same organization. So not being able to see what these files are going to look like, or wondering if there's going to be detailed instructions on what's going to be available, we're going to have a very difficult time with our vendor to get this thing posted automatically. And it's just going to create a ton of extra work on our side. That's why we're so concerned it's not seeing examples or having distinct instructions on what's going to be available.
It may be we're happy to have a follow-up, I would just say, with Carrie and Valerie, if it's helpful with your guys' team as a one-on-one. So we're happy to do that. And I think we might have, well, if this I think we already have one scheduled potentially, but if we need a separate one about this particular topic, we can also do that.
Okay, thank you.
So we are still developing that, but we should have on our side more information soon on that supplemental report.
And do you think, Sandy, is that something that is there like an example report would be able to be sent, like posted or something, so folks could see what that looked like? I don't defer to you. I don't know if that's feasible.
Okay, what was the question? Whether
Oh, just of that report, if there's like an example of what it would look like.
okay, I'm not sure I have that yet, but
No problem. We can talk
I do.
about it. We'll take
Okay.
it back and discuss it further and see if it makes sense. Obviously, we want to provide as much as feasible. There's just limitations, Carrie and Valerie, to what's like feasible when they put in the system. So I just want to acknowledge that, like, it's, there's just some current limitations. Obviously, we want to make it as easy as possible, acknowledging that there's just certain things we can and can't do. But happy to have that follow-up conversation if helpful. Any other questions? All right, well, thank you, everybody. We really do appreciate your time, and we understand we're asking and asking for a lot of changes at the provider level for implementation. We really do want to make this as smooth as possible, acknowledging some of the challenges that things will never be exactly perfect, but we are trying to be responsive when we can be, and when we think it makes sense and aligns with the program goals. So we do appreciate you being here. We appreciate your questions, and we really do anticipate continue to look forward to engaging with you. So we see this as success when, hopefully this works across the board, acknowledging, there will always be challenges, but look forward to talking soon. We'll have some more provider forums, and we'll be engaging with, I think, some of you in the very near future. And if you don't have one-on-one engagement and you'd like something, please feel free to reach out. Tiffany's been helping arrange those for us. Thanks, everybody.